Gallstones or cholelithiasis is most common in fatty female fertile 40 females. The female patients have increased risk to develop gallstones. Obese females have more risk. Age more than 40 years is a risk factor for gallstones. Diabetes mellitus due to dyslipidemia have increased risk for developing gallstone or cholelithiasis. We have same triad characterized by occurrence of gallstones, diverticulosis of diverticulosis of colon, and hiatus hernia due to shared risk factors of these conditions. So this occurrence of these distinct condition is called Saint's triad. We are now seeing the etiopathophysiciology of gallstones or cholelithiasis. The cholesterol gallstones contributes to for 6% of gallstones that we see in the normal population. The mixed type of gallstones occur in 80 to 90% of patients. It's the most common kind of gallstone seen. Then we have pigmented stones and brown gallstones. We are now seeing the pathophysiology of cholesterol gallstones. These are the cholesterol gallstones. Please don't think it as a chocolate. It's the result of consuming more and more chocolate. Okay. It's a radiating crystalline solitary stone which is formed due to excessive intake of fat, calorie, and obesity, and all, which we'll see now. The acetyl CoA, it's the end product of glucose metabolism, lipid metabolism, and protein metabolism, is converted to cholesterol. And then this cholesterol, some of it will get converted to bile acids by activation of 7-alpha hydroxylase enzyme. And because the reason for getting converted to bile acids is because cholesterol is hydrophobic. For it to be excreted from the body, it has to be converted to bile acids so that it becomes hydrophilic and it can be easily excreted through stools. Cholesterol, we humans don't have the enzymes to derive energy from cholesterol, so the only way is to get rid of cholesterol is to excrete it. So this cholesterol is converted to bile acids. That is the bile acid, the chenodeoxycholic acid and cholic acid are conjugated with glycine and taurine to conjugated bile salts. Those are taurochenodioxycholic acid and glycochenodioxycholic acid and other bile acids that are secondary conjugated bile salts. We have this cholesterol now, these bile salts, along with the phospholipids, lecithin. These three things get incorporated to form micelles. We have phospholipids here, we have bile salts here, and the hydrophobic cholesterol here. These things form micelles, which are responsible for excretion of cholesterol and also the absorption of fat soluble vitamin A, D, E, K. So the bile acids and cholesterol in the micelle should be at the ratio of 25:1, so that in this condition the cholesterol will be in liquid state. When there is increased intake of increased cholesterol levels in case of obesity, high calorie diet, and OCP intake, or decreased bile salts due to estrogens, ileal resection, which impairs the enterohepatic circulation, and also we have cholestyramine reducing the bile salts. This causes the impairment of ratio from 25:1 to 13:1. The bile acids to cholesterol ratio becomes 13:1. At this ratio, we see the formation of cholesterol crystals from liquid cholesterol. This form a nucleus, and this eventually forms the cholesterol gallstones. Then we have mixed stones, which are seen in around 80 to 90% of cases. These are multifaceted gallstones. You can see here. This occurs due to infection, the bacterial infection from tonsils, tooth, or from GIT. The organisms like E. coli, Proteus, and streptococci will reach the gallbladder through hematogenous route. Then these bacteria, along with the secretions in the gallbladder and inflammatory exudates, this forms a nucleus, a nidus, central nidus, around which the cholesterol and bile salts will accumulate and cause the mixed type of gallstones. Then we have pigmented gallstones. It's seen in hemolytic anemia patients, which can be secondary to hereditary spherocytosis, sickle cell anemia, and all. Due to hemolysis, there will be increased unconjugated bilirubin. The increased unconjugated bilirubin secreted into the gallbladder along with calcium forms calcium bilirubinate stones. These stones are seen as the small blackish pigmented stones. These are about pigment stones. Then we have brown pigmented stones, which are rare. It is due to the ascaris or clonorchis parasitic infection blocking the drainage of bile, thereby causing bile stasis inside the gallbladder, which predisposes to precipitation and formation of calcium bilirubinate, calcium palmite, calcium stearate, and cholesterol crystals, which forms brown pigmented gallstones. This is about the etiopathyphysiology of gallstones. Then we have clinical manifestations of gallstones. Please note the clinical manifestation of gallstone can range anywhere between dyspepsia to pancreatitis and perforation of gallbladder. The clinical manifestation related to gallbladder, we have it can be silent and asymptomatic in 10% of males and in 20% of females having gallstones. The pain, we have biliary colic and gallstone colic. These two types of pains are periodic severe pain, severe colicky pain occurring in right upper quadrant, and epigastrium, which radiates to chest, upper back, and shoulder. Periodicity meaning it will be present for some few hours and then it will go away, and then again on precipitation the patient will get the pain. The biliary colic is caused due to intake of meals mainly. Mainly, the fatty meals will precipitate the occurrence of biliary colic. Following intake of meals, there will be release of cholecystokinin. This CCK will cause contraction of gallbladder. Then these gallstones which are present inside the gallbladder can go and obstruct the gallbladder or gallbladder neck or cystic duct transiently, causing biliary colic. In case of gallstone colic, when at night, when the patient want to sleep peacefully, when he lies down in supine position, the gallstone goes and blocks the neck of gallbladder and cystic duct, causing the gallbladder spasm. And then due to this, the gallbladder stones causing neck of gallbladder and cystic duct blockage, there will be reflex pylorospasm. Along with the pain, the patient can have vomiting in case of gallstone colic. This is about the pain. And the patient with gallbladder stones can have the secondary infections. It can be acute cholecystitis empyema, which is a subtype of acute cholecystitis. In acute cholecystitis, there is bacterial infection of the gallbladder secondary to the erosion of the gallbladder mucosa by these irritating gallstones. The patient usually present with prolonged pain, severe pain in the right upper quadrant. He will have low-grade fever along with positive Murphy's sign. Murphy's sign is diagnostic of this condition, acute cholecystitis, where if we palpate at the right upper quadrant region and tell the patient to take deep inspiration, the patient will have mid-inspiratory arrest due to the fingers touching the gallbladder and causing acute pain. This is Murphy's sign. And we also have Boas sign, which is hyperesthesia at the posterior ribs, that is 9 to 11 ribs, due to the inflammation of gallbladder. These two signs will be positive. Then we have recurrent acute cholecystitis will cause fibrotic and thickened gallbladder, which is usually picked up in USG, called as chronic cholecystitis. The subtype of acute cholecystitis, we have empyema. Empyema is pus-filled gallbladder secondary to infection. The patient can have empyema. It may be due to severe acute cholecystitis or secondary infection of mucocele of gallbladder. Then we have another gallbladder manifestation, which can be perforation of gallbladder. The stone can erode the gallbladder wall and can cause perforation, causing biliary peritonitis, where the patient presents with acute severe abdominal pain, rigidity, and guarding. Then gallbladder stones is a risk factor for carcinoma gallbladder. The symptoms, clinical manifestation related to common bile duct. We have this gallstones can secondly migrate toward common bile duct and cause secondary CBD stones, that is choledocholithiasis, and it may cause after CBD stones, it can lead on to cholangitis, that is inflammation of bile duct. and these stones from bile duct can pass on to pancreatic duct or pancreatic duct and can cause blockade of the pancreatic duct and cause pancreatitis. We know the gallstones are one of the cause for acute pancreatitis. We can have Mersey syndrome where the gallstones at the gallbladder neck compress upon the common bile duct and cause obstructive jaundice. This is Mersey's type 1. We have spectrum of disease up to Mersey's type 1 to type 4. In type 4, there will be fistula formation between gallbladder and common bile duct. This is about Mersey's syndrome, which can occur in gallbladder stones. Then we have intestinal manifestation, that is cholecystoduodenal fistula. Rarely, these gallstones in the gallbladder can erode the gallbladder. Then, following that, the adjacent duodenum, second part of duodenum, and the gallstones can migrate from gallbladder to duodenum. Then, after going into duodenum, they can cause acute intestinal obstruction. It's about the clinical manifestation seen in cholelithiasis. Then we have the management of this condition. Investigations, we have USG. On doing ultrasound, the gallstones are seen with posterior acoustic shadowing. You can see here the posterior acoustic shadowing. Then we do CT scan to rule out common bile duct stones and liver function test. The increased the AST, ALT, and if AST, ALT levels will be increased in case of obstructive jaundice. Then we have treatment of this condition, the gallstones cholelithiasis. We have laparoscopic cholecystectomy. This is the ideal surgery that we can do in these patients. If the patient is not fit for surgery or we have difficulty in dissecting during laparoscopic cholecystectomy, we go on to perform open cholecystectomy through right subcostal pouches incision. So the indications for open cholecystectomy are if the patient is not fit for laparoscopic cholecystectomy, the patient has, if we suspect common bile duct stones, cholecystectomy, Mersey syndrome, and carcinoma gallbladder, we should do open cholecystectomy. And if the patient has asymptomatic gallstones, we can try dissolution therapy with ursodeoxycholic acid, but this is rarely effective. To summarize, gallstones occur most commonly in females, obese females who are more than 40 years, and diabetic patients. We have Saint's triad characterized by occurrence of gallstones, diverticulosis, and hiatus hernia, which are three distinct diseases. And the pathophysiology, we have cholesterol gallstones, mixed gallstones, pigmented and brown pigment gallstones. Cholesterol gallstones caused due to the impaired ratio of bile acid and cholesterol from 25 to 1 to 13 is to 1. The causes are obesity, high calorie diet intake, OCPs, and estrogen, ileal resection, and cholesterol intake. The mixed stones are caused due to bacterial infection, E. coli, Proteus, streptococci, causing nidus, central nidus around with the cholesterol and bile salts precipitate. We have pigmented gallstones occurring in hemolytic anemia, where we see the calcium bilirubate stones. We have brown pigment stones, which is a rare condition occurring due to bile stasis secondary to Ascaris or Clonorchis infection, where these stones have calcium bilirubinate, palmate stearate, and cholesterol crystals. Then we have clinical manifestation ranging anywhere between dyspepsia to pancreatitis and perforation of gallbladder. The gallbladder clinical manifestation can be asymptomatic, or patient can have biliary colic, gallstone colic. This pain is periodic, severe pain, which is colicky type at right upper quadrant, and epigastrium radiating chest, upper back, and shoulder. Then we have infections related to gallbladder stones, that is acute cholecystitis, chronic cholecystitis, and empyema of the cholecystitis, perforation leading on to biliary peritonitis and carcinoma gallbladder. The CBD related symptoms, clinical manifestations are CBD stones, that is choledocholithiasis, cholangitis, and pancreatitis. In the intestine, we have cholecystoduodenal fistula and cause intestinal obstruction. The gallstones causing intestinal obstruction. The management, we have ultrasound. The gallstones are seen with posterior acoustic shadowing. CT scan is done to rule out CBD stones, and LST will be impaired in obstructive jaundice. The increased level of AST, ALT. The laparoscopic cholecystectomy is the ideal procedure if the patient is not fit for surgery or we have difficulty In dissecting the gallbladder during laparoscopic cholecystectomy, we do open cholecystectomy. The other indications are if we suspect carcinoma, gallbladder, CBD stones, and Mersey syndrome, we do open cholecystectomy through right subcostal pouches incision. In asymptomatic gallbladder stones, we can give dissolution therapy, ursodeoxycholic acid, which is not so effective. Thank you for listening.